we go. Welcome everybody to another episode of The Big Idea. I am Dr. Jeffrey Hanna from Atlas Health, located here in North Lakes, Brisbane. What is The Big Idea? The Big Idea is where we talk about a topic that, maybe we could discuss in that length of time, but then really stretch it out. Why? Because by taking the time to walk you through and connect the dots between a lot of things, it gives people a lot better appreciation about different kinds of things going on in their body. And who is this, video cast for? A, it's for healthcare practitioners who kind of need to know this stuff. But B, and more important, it is for people who are dealing with these kinds of health challenges and issues so that they can have a better understanding, not just about what's going on, but more importantly, what they can do in terms of finding solutions that can possibly help them. And today we're going to be looking at what's known as Ehlers Danos syndrome. So as we're going to be getting the video cast rolling and streaming here, we will, as always, ask you guys to firstly like this video, and if you haven't already done so, click the subscribe button at the bottom. Why would you do that? Even if you are not familiar with this condition, if you know other people, or even if you don't know other people who are experiencing that, by clicking the button, it helps the internet algorithms to get that information out there for the people that it's able to help. So even if you don't watch this video all the way through to the end, we'd appreciate if you click, like, and that way you're able to help others. So let's walk you through a little bit on what this study, pretty much brand new, 2022, Craniocervical Instability in Ehlers Danos syndrome, a systematic review of diagnostic and surgical treatment criteria. So here we go. Let's rip through the summary here, and then we'll look at a little bit more of the detail. Here we go. Ehlers Danos syndrome comprises a spectrum of connective tissue disorders which may be associated with craniocervical instability. There is a lack of consensus on diagnostic imaging parameters, indications, and outcomes of surgical treatment. This then is some of the stuff that they're looking at. What do they come to the conclusion on entering their review? There is a lack of high-quality prospective evidence regarding the evaluation of suspected craniocervical instability in patients with Ehlers Danos syndrome. They give a few examples of a few things that are useful, and here's what they come to the conclusion. Surgical fixation of suspected craniocervical instability should only be performed in cases with clear radiographic presence of instability and concordant symptoms or signs. Consensus-based guidelines and care pathways are required. So, what does all of this mean? And why is it part of the reason that I am sharing this, particular, research review here with you is because over the span of the last probably year or so, I have been having more and more people reach out to me because they've gone onto the interwebs and they've come across videos or information where somebody is saying you could have Ehlers Danos syndrome, you could have Atlanto-axial subluxation, you could have cervical instability. But that's not necessarily what is going on. And so I want to walk you through using this particular research paper as a jump start to a discussion, what Ehlers Danos is, what it isn't, and how it relates to these different kinds of conditions, nevertheless, that can be going on in the upper part of the neck, and how you may not need to go to extreme lengths with needles and with surgeries and things like that in order to resolve these conditions. So I'm kind of going to be jumping all over this particular research paper, but as always, we will provide you with the link if you want to go through the whole thing on your own. Ehlers Danos syndrome affects 1 in 5,000 individuals, so it's not common, but it's not uncommon either. 1 in 5,000, that's pretty frequent. And it comprises a group of hereditary connective tissue disorders that are directly related to collagen synthesis deficiency, resulting in skin hyperextensibility, tissue fragility, and joint hyperextensibility. What does this mean? Genuine Ehlers Danos is a condition where the protein fibers that make up your muscles, your ligaments, your organs, every connective tissue in your body, as opposed to them being really, really solid, like a really thick rubber band, it's more like elastic, a really flimsy rubber band. And what it leads to then is it leads to where joints, muscles are excessively flexible. And we're not just talking about a person is a little bit flexible. You might be familiar with that expression going all the way back to elementary school. The idea of being quote unquote double jointed, that you could take the back of your thumb and that you could get it to push up against your forearm like that. Well, as you can see, I cannot physically do that. Why? That's a genetic thing. I clearly do not have Ehlers Danos syndrome. That is an entryway. Let's put it this way. If you cannot get your thumb to push the back of your forearm here, odds are you do not have Ehlers Danos syndrome. I'm going to put it out there right away. There might be the odd exception to the rule, but not really. But in the same breath, let me be abundantly clear about this. Just because you may be able to get your thumb to contact the back of your forearm does not guarantee that you have Ehlers Danos either. It could simply be that due to your genetics, that some of your ligaments are just a little bit more flexible than others. And just because the ligaments may be a little bit more flexible does not guarantee that you need to have the kinds of problems that are associated with it. And to that end, that's what we are going to skip ahead in the article a little bit here, because they talk about, I'll skip actually all the way down to their discussion here. Neurologic symptoms related to, okay, they're referring to craniocervical instability. We'll get there in a moment, but the two of them oftentimes go hand in hand. Are highly variable, multi-layered, and sometimes difficult to assign. In other words, there ain't just one thing. In a cohort of Ehlers Danos patients with Atlanto-axial instability, these guys observed a significant improvement in syncopal, presyncopal, and autonomic dysfunction after C1, C2 surgical fusion. So what these guys are saying is that they're saying that the symptoms associated with Ehlers Danos, they involve essentially pressure and dysfunction in and around the brainstem. What is the brainstem responsible for? It is the master control center for every function in your body. It sits at the gateway between the base of your skull and the upper part of your neck. No information, with the exception of vision and smell, goes up to your brain or back down to your body without going through that brainstem. And some of the different clusters that are associated in there are going to include the pathways and many of the cells that are responsible for motor coordination in all parts of your body. It's going to have the primary sensory relay stations from all of the information coming up from your body about pain, balance, sensation, hot, cold, all of that kind of stuff. And what it also is the hub of information that's called autonomic. Autonomic, in a nutshell, refers to blood flow, and it refers to the functions of your organs. Which organs? All of them. All of them. Your heart, your lungs, your digestive system, your reproductive system, your endocrine system. Not just the function of these organs coming from brain to the body, but also the sensory information coming back from body up to brain. My point being is that if you have a breakdown in this communication system in any way, it's going to lead not just to the potential of pain or altered sensations, it leads to altered function. And amongst the many different kinds of things that are associated with an Ehlers Danos, you're going to have not just headaches, migraines, but you can experience severe balance disorders to the degree that it's called like a postural orthostatic tachycardia, where you feel like your heart is always going really, really quick, that you're fainting or you're passing out, especially if you stand up quick. Seizure disorders are also very common. Fibromyalgia syndrome, very, very common. There's a whole plethora of different things. And if you want to, shameless plug, but really go to our website, atlashealth.com.au, where I post not just videos, but all kinds of different articles talking about the kinds of things that can happen if you've got an issue with the upper part of your neck at the level of your brainstem, just to give you some kind of an idea in terms of the overall severity of things. Now, spinal manifestations of Ehlers Danos syndrome have been described with higher attention only recently and include craniocervical instability, atlanto-axial subluxation, basilar invagination, and various spinal deformities. For example, segmental kyphosis. Craniocervical instability arises from ligamentous laxity with hypermobility and represents one of the most pertaining diagnoses for surgical intervention employing instrumented fusion. Morphologically, it results in cranial setting with clivo-axial kyphosis and ventral brainstem compression. What? Can you try that again? All right, let's rewind that. What did we say about the nature of Ehlers Danos syndrome? It is where your ligaments in particular are hyperflexible. And there is the ability to pop joints almost in and out at will. What joints? Potentially all of them. Not just thumbs or fingers or shoulders or knees. These are all super duper common. And these are some of the signs that point a person, okay, you may have one of these connective tissue disorders. But not just the joints of your extremities. This can also be the joints of your spine. And of particular concern are the joints that are in the upper part of your neck at the level of the brainstem. So I've got a few little models here for you as a bit of visualization. This here is a model of the base of the skull, including the opening right here where your brainstem would be sitting. So this is kind of the front side, this is the back side, and you might see these two little parts right here. These are the parts that come in contact with the top vertebra in your neck, called an atlas. It's the only one that's kind of shaped like a ring like this. Your brainstem sits here, and what your atlas does is it supports the weight of your skull. All 4 to 5 kilos of it like that. The atlas then, in turn, sits atop of what's called the axis, so the C2 vertebra. This is the junction that is responsible for you being able to pivot your head. It is the only joint in the spine that is constructed in this way, and that's going to be really important to our conversation a little bit later on. And so when you look at the architecture and the dynamics of C1 relative to the skull, which does this, so the nodding up and down movement, or at least 50% of it in your body, and then the rotation, that is 50% of all of it that you have in your neck like this, you're talking about 50% of the entire ability for you to move your head right in those two vertebrae right there. And so what's to stop, metaphorically speaking, your head from falling off your shoulders? Well, these vertebrae are strapped, guess what, to the base of your skull by ligaments. It's what holds, it what checks everything in order. And there's two particular kinds of ligaments that are important for our discussion. The first ones are called alar ligaments, and I don't know exactly how well I'm going to be able to do this, but I'm going to try for the sake of the camera so that you can see. We're going to look straight down through the base of your skull like this, and I'm going to try to hold the base of the skull like that. And you may be able to see, there we go, we've got it lined up almost. I'm trying to point out with my finger there, right there, that little bumpity thing that you see there, that's the top part of your C2 vertebra, which again is responsible for being able to allow you to pivot your head. And so what I wanted to show you here is that these alar ligaments are essentially where that's not right. Oh, this is terrible. Terrible demonstration, Jeffrey. Terrible. The ligament basically goes where my finger is right now. There's one on each side, and it runs from the skull and anchors into the side of that. There we go. There we go, like that. It runs like this, anchoring the base of your skull to the tip of that C2, so that even as you're moving your head, the whole thing does not come apart. There's another one, and this is called the transverse atlantal ligament. And what this does is this goes across the back of this groove right here between the front part of that C1 and the front part of that C2. And so it produces basically this little pivot point like that, that means that this vertebra is not going to just simply slip forwards and sever your spinal cord. That's going to be a problem. So what is the concern here? The concern is that if you are dealing with an Ehlers Danos type of condition and your ligaments by their architecture and their structure are more flexible than they ideally would be, it means, firstly, that if you're looking at that relationship between the C2 and the base of the skull with those alar ligaments in there that would normally prohibit movement, it means that you can start to have too much movement occurring kind of like this, between skull and C2. And essentially, what does that do? Well, if that's the opening where the base of your brainstem should be sitting, it has essentially the effect of pushing that C2 back into the spot, maybe not that much, but you get the idea. It narrows the opening and acts like a proverbial pebble in your shoe to irritate blood flow going to the brain, down from the brain, and on the brainstem itself. And in addition to that, you can also have stretching of that other ligament that I mentioned between the C1 and the C2, the transverse atlantal ligament. This I kind of already showed you. Is normally the joint should be designed to be able to pivot like this. And the problem is if that ligament's ever been injured or stretched, then what can happen is it offsets the center of gravity like that. Again, that C2 ends up poking into the area where your brainstem should sit, and it causes excess of an aberrant motion to be occurring in and through that area. And when you are dealing with genuine instability issues, as we said, these can cause some very severe neurological deficits to the point where surgical fixation, that is screws, surgery, is oftentimes necessary when you are dealing with the real deal. And by the real deal, I mean you've got the Ehlers Danos hereditary condition. You have confirmed that your ligaments are excessively flexible and you are dealing with some very, very severe neurological issues. Now, what they find for people who have this, and this is one of the challenges that they're having with Ehlers Danos, I repeat, it's become a little bit of a buzz diagnosis of late. And people are being diagnosed with it where who really may not actually have this going on. And we'll come to that, as I said, in just a little bit here. But for the interim, what these guys are pointing out in this particular research study is that when you have, because it's a hereditary, it's a developmental kind of condition, it means that you also start to see certain changes that pertain to the base of the skull, the shape of the base of the skull, things that set people up for developing neurological issues down the track. And so these are these particular measurements that they are referring to right here. In brief, the base of your skull with the C2 normally should be sitting kind of at an angle like that. And when you start to see where that angle flattens out, it means that it's far more likely then that that C2 can actually start to poke, not just be sitting below the base of the skull like this, but actually starts to penetrate and poke up. So that pebble in the shoe becomes even more pronounced, becomes worse. That then is compounded if and when those alar ligaments have been stretched. And so on imaging, you can see that the vertebra is sliding backwards, again, penetrating into that spinal canal right there. And then the third one is if, radiographically, you're seeing then that C1 on C2 has a huge amount of rotation that should not be there if a person believes that their head is in a neutral position. My point being is that there are ways that you can measure, you can identify these different kinds of things. But what I want to do is I want to bring this back around for a second here now. And I want to come to the conclusion that these guys are talking about in this particular paper and as it relates to Ehlers Danos. Based on the current literature, there is a significant lack of evidence for the evaluation and management of suspected craniocervical instability in Ehlers Danos patients. As a next step, consensus-based guidelines and care pathways are required. And that brings us back to this line that they said right here. And let me re-emphasize a few of these key words. Surgical fixation of suspected craniocervical instability should only be performed in cases with clear radiographic presence of instability and concordant signs and symptoms. Consensus-based guidelines and care pathways are required. What does this mean? It means that there's no one fancy test for Ehlers Danos syndrome. It means that you have to go through a series of checks in order to figure out what's actually going on. The simple one that I say you start with, again, can you get your thumb to touch the back of your wrist? If the answer is no, you don't have Ehlers Danos syndrome. Mostly, you don't have it. If you can disarticulate and make your fingers pop in and out, or your shoulder, your other extremities, or your knees, okay, it's very possible then that you do have the true Ehlers Danos syndrome. If that is the case, there might be certain genetic tests and genes that you can look for to identify if that's the case. But what these guys are also saying is just because you may have stretchy ligaments does not necessarily mean that you have to go on to experience all of these different kinds of neurological issues. In fact, what they say is A, if you've even got a concern about this, maybe not a bad idea having an MRI or a couple tests, something like that, to see, do you have any of these other structural risk factors that could possibly produce instability, excessive movement that would affect your brainstem? If the answer is no, well, that's a good thing. And guess what? It should probably leave you alone. But if you do, and only if A, you're finding signs of severe instability here, and B, that's causing the very serious signs and symptoms we've talked about, it's really only then that people really may need to seriously consider surgical fixation, screws and all that to hold things into place. So that's the true Ehlers Danos. Now, why does this matter? And this is kind of the end of this particular, talk on the paper here. It's because Ehlers Danos and the idea of cervical instability and excessive movement and hypermobility and clicking that goes on in the neck, and it feels like your head is heavy and there's brain fog, and all of these other kinds of symptoms associated with Ehlers Danos, well, guess what? It doesn't have to be Ehlers Danos that causes that in the first place. And it seems that one of the major forms of treatment that's being proposed for people with this supposed instability is what's known as prolotherapy. What is prolotherapy? Prolotherapy is a medical procedure. It's physical medicine is what it's called. And what they do is they do an injection of various solutions into a ligament. The idea being is that if you've got an excessively stretchy ligament, the solution is going to act like a glue that allows your body to tighten that kind of ligament. So if you are experiencing symptoms associated with ligament laxity, that can help to solidify it, and as the ligament heals, those symptoms and those problems go away. And what they find is when people do have varying degrees of ligament instability, whether it's in an ankle or a knee or a shoulder or even in the joints of the neck, that it can help to significantly reduce pain and other problems that people experience. I am not against prolotherapy in that regard, even though it might sound like I'm going to be coming from that perspective. However, and the reason that I am doing this video is to let people know that prolotherapy may not be the complete solution. I'm not going to say that I have the complete solution either. But my point is going to be, as I'm going to walk you through this, that the prolotherapy may also only be part of the overall solution. So let's come back now to the idea of ligament laxity. And in order to go through this, I need to explain that there are 3 different kinds of ligament sprains in a general nutshell. The most severe is what's called a grade 3 sprain. It's where all them fibers are completely torn and you've got pieces moving willy-nilly like this. The idea of conservative therapy, no, that is surgery, full stop. You're not going to get the 2 bits to be able to come together without proper surgery there. And how can something like that happen? Physical injury is a short, nasty physical injury. The second kind is what's going to be called a grade 2 injury. And these are what are usually called the unstable injuries, the kind that we've been talking about over the course of this video. What this is where you have joint surfaces like this that normally are held in check and are normally designed to move something like this. But again, there's been a physical injury that's either torn 30 to 75% of the fibers, or has caused the joint surfaces to offset by approximately 50%, producing what is medically called a subluxation. It's not a full dislocation, it's not a fracture either. It's where the joints are offset by a very, very significant margin. And as a consequence of that, they're not moving properly, they're moving way too much. But it means then that the entire rest of the body's muscular system and also its neurology are in a real battle to maintain that balance, because if that balance ever gets tipped, then you're dealing with all kinds of severe issues, especially when you're dealing with issues in the upper neck. Because if you're dealing with true blue grade 2 unstable injuries in the upper part of the neck, These are the kinds that can be putting pressure on that brainstem. These are the kinds that are potentially dangerous if a person is working on that, whether that's a chiropractor, a physiotherapist, a massage therapist, a GP, or anybody else for that matter who's not aware of the condition going on the inside. Because if you push it the wrong way, you can really piss the situation off. Now, you can usually get it back in under control, but you got to be really, really cautious with those kinds of things. Sometimes they do require surgery. Other times you can manage them appropriately with those exact same therapies that I mentioned, including the chiropractic, the physiotherapy, the massage therapy. But you, A, have to be very, very cautious, and B, you have to make certain that your direction is always appropriate. And I use this as a very simple example. Let's say that you were dealing with that condition where that ligament has gotten stretched a little bit right through the back here. What that means is it means that under no uncertain terms should you ever push that vertebra from back to front, because guess what? That's going to make that an awful lot worse. However, there may be instances, if you are being very light, very cautious, and this is also where prolotherapy comes into the equation, where you can tighten the ligament, you can work to support the area around that, but you may be able to do different kinds of things that work congruently with the alignment of the joints in order to help resolve that issue. Nevertheless, oftentimes surgery may be necessary for these kinds of people. But now let's come to the third type of condition, and this is the grade 1 injury. A grade 1 injury, this is a micro tear. This is not where you're dealing with a unstable dislocation, although in the literature, they commonly and very infrequently make no distinction between them, even though there's a very big distinction. Both of them can produce the exact same symptoms. The difference is one is unstable and the other is stable, but it just isn't moving properly. And if it's not moving properly, it's going to be causing clicking, grinding when you are turning, moving your head. It can give you the sense of a heavy head sensation. It can give you the sense of blood flow not going properly to and from your brain. It can affect the direct function of brainstem itself and again produce all of the exact same kind of symptoms. But this is not necessarily a case of instability. No, what this usually is where you have had a micro tear of one of the ligaments somewhere in the spine. And as a consequence of that, it's not moving properly. And so what does your body do if one part is not able to move properly? It's going to compensate by making adjacent areas of the spine move just that little bit too much. And usually that's a good compensatory strategy if and when you're able to resolve the issues within a few weeks or maybe a few months. But unfortunately, what so many people do is they say, oh, I don't have any pain, I don't have any symptoms. No, I'll be right. Or, oh, maybe I'm starting to feel a little sore and tight. Oh, I guess it's just because I'm getting a little bit older. Oh, maybe it's just a little bit stressed. They come up with all these reasons why they don't do anything about it. And all the while, this little problem starts to build up. So if you've got that one area that's not moving properly or not moving well enough, that other area is having to compensate more and more and more and more. And so what happens if you have a piece of string or a piece of elastic or anything for that matter that you keep stretching like this, little bit by little bit over a long period of time, it starts to become more elastic and it starts to lose its support. And this is my point. That is not the same as Ehlers Danos syndrome. It still produces a little bit of ligament excessive flexibility, maybe a bit of hypermobility, and guess what? It can also produce many of the same symptoms. But it's got a completely different cause, and thus a completely different kind of solution. These are the kinds that oftentimes respond the best when you are able to resolve that whatever is causing and has ever gotten jammed and locked up. Because if you can resolve that kind of an issue without having to resort to needles or drugs or surgery and all of that fun stuff, that what it means is it means that your body says, oh, well, we no longer need to compensate for that. And over a period of time, that ligament starts to tighten and it's able to start coming back. And so this is why, again, I'm not against prolotherapy. It's simply that you can have an injection into a joint, into a ligament. However, even if you're in the right spot, and even if that's helping, if there is still another part that is not quite moving the way that it should be, the body is eventually going to say, it's like, hey, no, we need that excessive amounts of flexibility and the hypermobility there, otherwise it's not going to work. And that's one of the frustrating challenges there. And it's also then the appreciation why I'm doing this video, is because it's oftentimes not just a matter of the prolotherapy, but it's oftentimes a matter of making sure that not just excessive joints, but that you're looking to find, are there other joints, particularly the joints above and below the atlas and the axis, that are moving correctly. Because if either one of those, which are very, very commonly not moving properly in people because of physical injuries and they don't even know it, if that's not moving properly, then it means that the spot that needs to do the very most amount of compensation is that area between C1 and C2. Which brings us back to something I mentioned in the very beginning. You will recall that I said C1 on C2 is the only joint in the spine that moves this way. Every other joint essentially is orientated like this, or like this, which means that it provides very good two-dimensional movement, but it doesn't provide any amount of what's called axial rotation. So if any of those joints was to ever lock up and your body then produces postural distortions to try to compensate for that, one way or another, that C1 and that C2 joint is going to be engaged. What that means is it means that if you have an injury, whether it's in the upper part of your neck, the lower part of your neck, your lower back, or even your foot and your ankle, as your body tries to compensate for that, that C1 on C2 is going to engage. And if that C1 and C2 engages for a long period of time, guess what? That ligament is going to start to stretch a little bit. And when you turn your head, it's going to click and it's not going to feel right. And oftentimes you feel like you've got a bit of a headache, dizzy, maybe even a migraine. These are all very, very commonly associated with that area. And my point is that if you focus solely on trying to fix that ligament at C1 and C2, without looking at the entire rest of the system for why those ligaments are moving abnormally in that way, it means that you may not be able to get the complete resolution that you are looking for. So my point, as I'm rounding out and as we're finishing up this video here, firstly, if you are experiencing these symptoms and you've come to the conclusion from doing some of your research here that you could have an Ehlers Danos, or that you could be dealing with cervical instability or Atlanto-axial instability, it's always a good idea to have the good proper medical check to make sure that you either are or aren't dealing with these things. Whether you do or you don't, it's nevertheless, at least in my opinion, it's worth then also getting yourself properly checked by somebody who focuses in making sure that these joints are also aligned and moving the way that they are supposed to. My role as an upper cervical chiropractor is emphasizing, are the joints in the upper part of your neck moving the way that they should be? If the answer is yes, hands off, leave you alone, you're fine. If the answer is no, particularly if something is locked up, then we don't want to stretch or crack or twist, do anything like that to your neck. No, what we then do is we measure to find out, okay, what's the exact direction degree that this thing has gotten locked out of its normal position? And then how can we, in the lightest form possible, work to correct that, to bring it back in under your body's control, and by restoring the balance and the normal motion there, be able to take the pressure off of the other areas so that your body can do what it is supposed to do, and that is heal itself naturally. And as that happens, what we often find is that people say, I can move my neck so much easier. I'm not having the same amounts of pressure, the same amounts of pulling. All of the other things that they thought was related to an instability issue, which in reality was due to a misalignment issue. And an issue then, in that case, that may be able to be corrected without the surgery, without the needles, without medications, but by just getting that segment properly lined up and moving in the most effective, safest way that it possibly can be. So that's the kind of thing that we look at. Could there be other bits and pieces also associated with it? Short answer is yes. But especially if you are dealing with issues up in this area, it's probably a good idea getting that checked out, getting that assessed to find out, what would be the different kinds of options, what can be done to help you out so that you can get the best possible chance of results so that you can get back to enjoying the quality of life that matters most to you. Again, whether or not you actually have this particular condition. So thank you guys for watching this video here. I do hope that you've enjoyed it. And as we're wrapping up, as always, I will ask you the same things as we are finishing. So first and foremost, if you didn't do that in the beginning, please do click the subscribe and the like button here so that this information becomes available to other people who need to find it. Number two is if you know somebody who either experiences these things, they have arthritis in their neck, Ehlers Danos syndrome, their neck clicks or cracks, or experience other kinds of symptoms, please do share this video with them so that they might be able to take the next step and find out something that's able to help them. And the third step, and this is more for, of course, the people who would be in our neck of the woods, it would be that if you are looking for, help, if you are looking for options, if you're looking for solutions for these different kinds of things, then please do reach out to us. This is what we do all day, every day. Our office is, and just the details, if you're looking for more videos and information about what we do, how we do it, you go visit us at www.atlashealth.com.au, where we've got videos, blogs, as we said, all kinds of different information about the different kinds of conditions that people experience when they oftentimes come to see us. So you can check us out there for information. You can also check out all of the other videos that we have on our channel here, so that way you've got a much better idea in terms of what we may be able to do to help you out, because information is good for the sake of knowledge, but it's not until you actually take that information and do something with it, that's when that action actually transforms into something that's got that potential to transform your life for the better. So thank you guys again for watching this video. So until next time, take care. Bye-bye.